All right, so the world of myeloid pathology has just been completely turned on its head. If you're a pathology trainee, the new CAP protocol is, without a doubt, your most essential guide for navigating this new landscape. And today, we're going to break it all down for you.
So, have you ever cracked open the new WHO 5th edition and just felt overwhelmed? It's like staring at a phone book of diseases. If that's you, don't worry, you're not alone. And you can think of this explainer as your GPS to get through all that complexity.
Okay, first things first, let's just set the boundaries. This protocol covers a massive range of things, everything from myeloid precursor lesions all the way to acute leukemias. But, and this is really important, you have to know what it doesn't cover. It excludes precursor lymphoid malignancies and most of those histocytic neoplasms. Think Langerhans cell histiocytosis. Those have their own separate guidelines.
So here's our game plan. We're going to take a tour through 5 key areas. We'll start with the why behind the standardized protocol itself. Then, we'll dive into the massive conceptual shift from the WHO 5th edition. After that, we'll highlight some critical updates in myeloid neoplasms, look at how to pull in all your ancillary studies, and finally bring it all together to craft that final diagnosis.
You know, it's so easy to look at a CAP protocol and just see a checklist, right? Something to tick off. But for these incredibly complex cases, it is so much more than that. It's really a blueprint for building a clear, consistent diagnosis that beautifully weaves morphology together with all your other ancillary data. Now, what's really driving all of this is a fundamental, foundational shift in diagnostic thinking, and it's all coming from the WHO 5th edition. And I want to be clear, this isn't just shuffling a few categories around. No, this is a whole new philosophy for how we even approach these diseases.
For years, for decades, our entire diagnostic world was built on what we saw under the microscope. Morphology was king. The shape of the cells, the patterns of infiltration, the amount of dysplasia, that was the bedrock of how we classified everything.
And now, the whole paradigm has flipped. It is now genetically driven. Specific molecular abnormalities are now the defining features for so many key diagnoses. And what this does is it creates these biologically consistent categories. We're moving away from what the disease looks like to what the disease is at a molecular level. And that, of course, has massive implications for targeted therapies and for patient prognosis.
Okay, so that's the big picture. But what does this actually look like when you're at the scope? We can't cover every single change today, but let's zoom in on 2 really high-impact areas you are definitely going to see every day: myelodysplastic neoplasms and acute myeloid leukemia.
For MDS, the big story is this brand new structure. You have to start thinking genetics first. MDS is now basically split into 2 main buckets. One is defined by those very specific genetic abnormalities, and the other bucket is for cases that are still defined by their morphology. This split just gives us so much better diagnostic consistency and way clearer prognostic information.
And this table here, this is your high-yield summary. You absolutely have to know these 3 new genetically defined MDS types, both for signing out cases and for your boards. You've got MDS with 5q deletion, MDS with an SF3B1 mutation, and then the really poor prognosis MDS with biallelic TP53 inactivation. These are really the new cornerstones of how we classify MDS.
For as long as I can remember, there was one magic number in hematolopathology: 20%. That was the blast count, the hard and fast threshold you had to cross to diagnose most acute myeloid leukemias.
Well, guess what? That rule, it's gone. For a whole bunch of AMLs that are defined by their genetics, you can just throw that 20% blast threshold right out the window. This is honestly one of the biggest, most significant changes in the entire classification.
So what does this mean for you day to day? It's simple. If your molecular lab calls you up and says they've found a key genetic alteration, like a RUNX1 fusion, a KMT2A rearrangement, or an NPM1 mutation, you diagnose AML, period. It does not matter if the blast count is 5% or 15%. This is a huge practice-changing update that just hammers home this new genetics-first approach.
So, that begs the question, right? We've been talking all about these genetic drivers, but how do we actually find them? Well, this is where the Special Studies section of the CAP protocol basically becomes the engine room of the modern diagnosis. It's how we get the data to define these new entities.
This is it. This is the modern diagnostic workflow in action. It's a journey. And yeah, it always kicks off with morphology. Our eyes on the slide give us those first crucial clues, but that's just the starting pistol. From there, we integrate immunophenotyping from flow cytometry, chromosomal data from cytogenetics, and then, finally, that deep dive for molecular profiling. It's the synthesis of all these parts that builds our final precise, integrated diagnosis.
All right, let's bring it all home. Let's boil it all down. When you sit down with your next myeloid case, with this protocol in front of you, what are the absolute key things you need to remember?
Just remember these 3 things. 1. The protocol is your roadmap, not just a simple checklist. Use it to actually structure your thought process. 2. Genetics is king. The entire new classification is built on defining these molecular alterations. And 3. Integration is everything. The final diagnosis is a synthesis of all the data you have.
So the next time a really complex bone marrow lands on your desk, think about this framework. Ask yourself, how can I apply this genetics-first, integrated approach? Because honestly, understanding the why behind the protocol, that's not just about passing an exam. That's about truly mastering myeloid pathology and delivering the most accurate diagnosis possible for your patients.